Welcome back to the deep dive. Today, we're really getting into something fundamental, the body's reaction to getting hurt. We're focusing on inflammation, tissue repair, and how wounds heal, using Porth Pathophysiology as our guide. Our goal here is pretty clear. We want to unpack that whole sequence, from the initial injury right through to the final scar. And the idea is to help you really visualize it, connect the dots between the tiny cellular stuff and what you actually see in patients, all without needing pictures. So the big concept, inflammation isn't just about damage. It's actually a two-sided coin. First, you neutralize whatever caused the problem, toxins, bugs, whatever. But at the same time, you're prepping the area for the next stage, repair, fixing the damage.
Exactly. And that repair part, that's where things get really interesting clinically. Because if that whole inflammatory system goes haywire, if it doesn't switch off right or attacks the wrong thing, well, that's the root of so many major diseases. We're talking things like severe asthma, those dangerous plaques in arteries causing heart attacks, diabetes complications, and autoimmune disorders. Fundamentally, inflammation is just how tissues with blood supply react to injury. Simple as that. And you always know it's inflammation because of the name. It ends in -itis, like appendicitis, inflammation of the appendix, or pericarditis.
Okay, so what are the immediate signs? These have been known for ages, right? Since the 1st century, AD, Celsus and Galen. The 5 cardinal signs: rubor, that's redness; tumor, swelling; calor, heat; dolor, which is pain. And the last one, functio laecita, meaning loss of function. But inflammation isn't just one thing. It was acute and chronic. What's the difference there?
It really comes down to timing and the cells involved. Acute is the immediate short-term response. We're talking minutes to maybe a few days. It's protective. The goal is to get rid of the bad stuff fast. Think lots of fluid rushing out, exudate, and the main soldiers are neutrophils. They're like the first responders.
And chronic.
Chronic is the long haul, days to years. It means the body hasn't managed to clear the problem, and the cell types shift. Instead of neutrophils, you get lymphocytes and macrophages dominating. Plus, you see new blood vessel growth, scarring fibrosis, and often tissue damage, necrosis.
Okay, let's stick with acute for now. You said it's a 2-phase process.
Highly coordinated, yes. First, the vascular phase changes in the blood vessels. Second, the cellular phase, getting the white blood cells, the leukocytes, to the site.
So the vascular phase, how does that cause those cardinal signs like redness and heat?
It starts almost instantly. A brief tightening of the vessels, vasoconstriction, then boom, strong, lasting vasodilation. The vessels open wide. That increased blood flow through the capillaries. That's your redness. And the heat, calor. Pretty straightforward.
Right, but the swelling, pain, loss of function, that seems more complicated.
It is, slightly. That comes from increased vascular permeability. The vessel walls become leaky. So not just fluid, but protein-rich fluid, the exudate, escapes into the tissues.
Oh, okay.
Losing that protein from the blood vessel lowers the osmotic pressure inside, while the protein accumulating outside pulls more fluid out. That's your edema, the swelling, the tumor.
And the pain.
That swelling puts pressure on nerve endings. That causes the dolor, the pain. And when it hurts and swells that much, you tend not to use that part, hence functio laesa, loss of function. But there's a neat trick here. This whole process, the leaky vessels, the fluid loss, actually makes the blood flow slower right at the injury site. Stasis.
Why is slowing blood flow good?
It helps promote clotting. And that clot acts like a barrier, walling off the area. It helps stop infectious agents from just spreading everywhere through the bloodstream. It's containment.
Okay, so the stage is set. Vessels are wide, leaky, flow is slow. Now we need the troops, the cellular phase.
Exactly. Time to deliver the leukocytes, particularly the neutrophils, early on. First step, margination and adhesion. The leukocytes kind of drift to the edges of the slowed blood flow and start sticking to the vessel lining, the endothelium.
How do they stick?
Using special molecules on their surface and on the endothelium, like selectins and integrins. It's like molecular Velcro.
Okay, they're stuck. How do they get out?
That's transmigration or diapetesis. They basically squeeze themselves through temporary gaps that open up between the endothelial cells. It's quite the maneuver.
And once they're out, how do they know where to go? It's not just random wandering, right?
Definitely not. That's chemotaxis. They follow a chemical trail.
Like breadcrumbs.
Sort of, yeah. Chemical breadcrumbs, chemotractants. Things like chemokines or bits of complement proteins like C3a and C5a create a gradient, strongest at the injury site. The cells just follow the scent, moving towards the highest concentration.
So they arrive at the target. What's the kill step?
Phagocytosis, eating the enemy. But first, recognition.
How do they recognize bacteria or debris?
Often it's helped by opsonization. Think of it like tagging the target. Antibodies or complement proteins coat the microbe. This coating, opsonization, makes it much, much easier for the phagocytes, the neutrophils, and later macrophages to grab onto the microbe.
So they grab it, then what?
They engulf it, wrap their membrane around it, forming a little bubble inside the cell called a phagosome.
Okay.
Then this phagosome fuses with another internal sac called a lysosome, which is full of digestive enzymes and nasty chemicals.
Creating the phagolysosome.
Exactly. Inside that merged sac, the phagocyte unleashes toxic stuff, reactive oxygen species like hydrogen peroxide, nitric oxide, plus enzymes to kill and break down the microbe. Job done.
Let's just recap the main cell types involved here. You mentioned neutrophils first.
Right, neutrophils, also called PMNs or SEGs, they're the shock troops, arrive super fast, within 90 minutes. A high count in the blood, leukocytosis, often points to bacterial infection. If the infections are really bad, the bone marrow might even release immature forms called bands. That's called a shift to the left.
But they don't stick around forever.
No, they're short-lived. That's where the monocytes macrophages come in. They arrive a bit later, maybe 24, 48 hours.
And they're different how?
They're bigger, live much longer, and can eat a lot more stuff. They're crucial for cleaning up the mess, dead neutrophils, damaged tissue, remaining microbes. And critically, macrophages are the ones that really manage the transition from inflammation to healing. Without them, the wound just stalls.
And we shouldn't forget the endothelial cells themselves, the vessel lining. They're not just passive pipes.
Absolutely not. They respond to mediators, control the permeability, express those adhesion molecules, and later they're key in producing growth factors for repair, for building new blood vessels, angiogenesis.
Okay, so all this action, the vasodilation, the cell movement, the symptoms, it's all driven by chemical signals, right? Mediators.
Precisely. These chemical mediators orchestrate the whole thing. Some circulate in the plasma, made mainly by the liver, like complement proteins. Others are released directly from cells at the site.
Which ones are the first responders, chemically speaking?
Histamine is a big one for the immediate reaction. It's pre-made and stored in granules inside mast cells ready to go. When released, it causes that rapid vasodilation and increases permeability, especially in the small veins, the venules. It's responsible for that initial transient phase.
Which is why antihistamines work for things like hives or runny noses. They block histamine receptors.
Exactly. They block the H1 receptor, counteracting those immediate effects.
What about mediators that act a bit later or longer?
Then you get into the arachidonic acid metabolites. This is a really important group. Arachidonic acid is a fatty acid in cell membranes, and it can be processed down two major pathways.
What are the pathways?
The cyclooxygenase pathway makes prostaglandins, PGs. These are major players in inducing inflammation, pain, and fever.
And that's where common painkillers come in. Aspirin, NSAIDs like ibuprofen.
Yes, precisely. Aspirin and NSAIDs work by blocking cyclooxygenase, the first enzyme in that pathway. So less prostaglandin synthesis means less inflammation, less pain, less fever.
But if prostaglandins are part of the normal inflammatory response, are we potentially slowing down healing by blocking them?
That's the million-dollar question, isn't it? It's a trade-off. You reduce the symptoms, which is often necessary for comfort and function, but yes, you might be dampening some signals that are actually helpful for the overall resolution and repair process. It's context-dependent.
Okay, and the other pathway for arachidonic acid?
That's the lipoxygenase pathway, and it produces leukotrienes, LTs. These are generally more potent than histamine in certain actions. They increase vascular permeability, but they're also powerful chemoattractants for neutrophils.
Any specific clinical relevance for leukotrienes?
Oh, absolutely. A specific group, LTC4, LTD4, LTE4, used to be called the slow-reacting substance of anaphylaxis, SRSA. They cause prolonged, slow contraction of airway smooth muscle, very important in the pathology of bronchial asthma. That's why some asthma medications specifically target leukotriene pathways.
So sometimes this local inflammation gets bigger.
Yeah.
Spreads throughout the body.
Yes, that's the acute phase response. It's basically systemic inflammation. Happens when the local mediators, especially potent cytokines like interleukin-1, IL-1, tumor necrosis factor alpha, TNFO, and interleukin-6, IL-6, spill into the bloodstream in large amounts.
And what does that look like for the patient?
Systemic effects. These cytokines hit the brain, specifically the hypothalamus, and reset the body's thermostat, causing fever. They also trigger the breakdown of skeletal muscle protein catabolism to free up amino acids needed for making new proteins for repair and for the immune response.
In the white blood cell count.
It shoots up. Leukocytosis. Normal might be 4,000 to 10,000 cells per microliter. In acute inflammation, it can easily jump to 15,000, 20,000, or even higher. The liver also gets involved, pumping out acute-phase proteins. Fibrinogen is one, which you need for clotting. Another key one is C-reactive protein, CRP.
CRP. I've heard of HSCRP being used for heart disease risk.
Exactly. High sensitivity CRP, HSCRP, measures low levels of chronic inflammation. Elevated HSCRP suggests inflammation within atherosclerotic plaques in the arteries, indicating a higher risk of plaque rupture and therefore myocardial infarction. It links inflammation directly to thrombosis risk.
What's the worst case scenario for systemic inflammation?
That would be sepsis or systemic inflammatory response syndrome. SRS. It's an overwhelming, uncontrolled inflammatory response. Massive cytokine release causes generalized vasodilation, incredible fluid loss from the capillaries into tissues, low blood pressure, impaired tissue perfusion. Basically, shock. It's a life-threatening emergency.
Okay, so that's acute. What happens when it drags on and becomes chronic inflammation?
Well, sometimes it's chronic from the start if the irritant is low-grade but persistent. Or it can follow an acute episode that didn't resolve. There's a sort of general, non-specific chronic inflammation. Here, you see a buildup of those longer-lived cells, macrophages, and lymphocytes. Instead of resolution, you get ongoing inflammation, fibroblast proliferation. They're the cells that make scar tissue, and eventually, scar formation replacing functional tissue. Think of chronic inflammation narrowing the lumen of the bowel, for example.
Is there a more specific type?
Yes, granulomatous inflammation. This is quite distinct. It's the body's attempt to wall off something it finds really hard to get rid of.
Like what?
Classic example is tuberculosis bacteria, or foreign objects like splinters, suture material, silica dust. The body forms these tiny nodules called granulomas, about 1 to 2 millimeter across. At the center are macrophages that have transformed into epithelioid cells, trying to contain the agent. Sometimes they fuse together to form giant cells. It's basically an isolation strategy.
Locally, does the type of fluid produced tell us anything? The exudate.
It absolutely does. The character of the exudate reflects the type and severity of the injury. Serous exudate is watery, low protein, like the fluid in a blister. Hemorrhagic means there's significant vessel damage, so red blood cells are leaking out, looks bloody. Fibrinous exudate is thick, sticky, contains a lot of fibrinogen, often seen in body cavities like pericarditis. And purulent or suppurative exudate, that's pus. It's full of neutrophils, dead and alive, degraded tissue debris, and often the microbes themselves.
Pus, that brings us to abscesses.
Right. An abscess is a classic example of localized, purulent inflammation. It's a collection of pus walled off by neutrophils and later fibroblasts trying to contain it. And here's the clinical kicker. That wall is really effective at keeping things in, but also keeping things out. Antibiotics circulating in the blood often can't penetrate that abscess wall effectively.
So just giving antibiotics might not be enough.
Often not. That's why abscesses frequently require surgical incision and drainage IND to physically remove the pus and allow healing. You have to break down the barrier.
Okay, shifting gears slightly to tissue repair. Assuming the inflammation is controlled, how does the body actually fix the damage?
Two main ways. Either regeneration, where the damaged cells are replaced by identical functional cells, or replacement, where the damaged tissue is replaced by connective tissue, forming a scar.
What decides which way it goes? Regeneration sounds much better.
It depends entirely on the type of cells that were damaged and the extent of the injury. Cells fall into 3 groups based on their ability to regenerate.
Okay, what are they?
First, labile cells. These guys are dividing all the time as part of their normal function. Think skin epidermis, the lining of your gut. Bone marrow cells, they regenerate readily. Stable cells. These normally are dividing, they're quiescent in G0 phase, but if injured, they can be stimulated to re-enter the cell cycle and divide. Examples include liver cells, hepatocytes, kidney tubule cells, smooth muscle cells, so the liver can regenerate pretty well up to a point.
And the third type, this sounds like the problematic one.
It is. Permanent or fixed cells. These cells are terminally differentiated. They left the cell cycle way back and cannot undergo mitotic division again.
Like what kind of cells?
Nerve cells, skeletal muscle cells, and crucially, cardiac muscle cells.
So if you damage those?
They're gone for good. The body can't make new ones. The damaged area gets filled in with fibrous scar tissue, which lacks the original function. That's why a heart attack, which kills cardiac muscle, leaves a non-contractile scar. The heart is permanently weakened.
Let's talk about the healing process itself. Is it different for, say, a clean cut versus a big scrape?
Yes, we talk about healing by primary intention versus secondary intention. Primary intention is for clean wounds with minimal tissue loss, where the edges are brought close together, like a sutured surgical incision. Healing is faster, less scar. Secondary intention is for larger wounds with more tissue loss, like a large ulcer, burn, or infected wound. The wound edges are far apart. It has to fill in from the bottom up. This takes longer, involves more inflammation, more granulation tissue, and results in a much larger scar.
But the basic phases of healing are similar.
Yes, the underlying biology follows three overlapping phases, especially clear in primary intention.
Phase 1.
The inflammatory phase starts right at injury. First, hemostasis, stopping the bleeding with vasoconstriction and clot formation. Then, the vasodilation and permeability changes we discussed, bringing in the phagocytes neutrophils first, then macrophages to clean up debris and bacteria. Macrophages are absolutely essential here to signal the next phase.
Okay, inflammatory phase cleans the site. What's next?
The proliferative phase. This kicks in around day 2 or 3 and can last up to 3 weeks. This is all about rebuilding.
Who were the main builders?
The key cell here is the fibroblast. These cells migrate into the wound and start synthesizing and depositing collagen and other extracellular matrix components, forming the scaffold for repair. At the same time, you get angiogenesis, new capillary growth sprouting from existing vessels. This network of new capillaries plus the fibroblasts and ECM forms a tissue called granulation tissue. It looks pink and granular.
Is that the stuff that sometimes looks like it's growing too much?
Exactly. Sometimes you get proud flesh, excessive granulation tissue that bulges above the surface and actually blocks epithelial cells from migrating across and might need to be surgically removed. And the other key part of proliferation is epithelialization. Skin cells at the wound edges migrate across the surface to cover the defect.
So inflammatory phase, proliferative phase. What's the last one?
The remodeling phase or maturation phase. This starts around 3 weeks and can continue for 6 months or even longer. Here, the granulation tissue scaffold is gradually replaced by more mature scar tissue. There's ongoing synthesis of collagen, but also breakdown of previously laid collagen by enzymes called collagenases. This constant turnover remodels the scar, increasing its tensile strength. It never quite reaches the original strength of undamaged skin, maybe 70–80% max. The scar also tends to contract, shrinking over time.
And problems here can lead to things like keloids.
Yes, keloids are basically excessive scar formation where collagen synthesis goes into overdrive and extends beyond the original wound boundaries. It's like a benign tumor of scar tissue.
Okay, super important clinically. What things mess up this healing process? Factors that impair wound healing.
Lots of things, unfortunately. Let's start with systemic issues. Malnutrition is huge.
How so?
Healing requires building blocks. Protein deficiency slows down inflammation resolution, impairs fibroblast activity, and reduces collagen synthesis. Vitamin C is absolutely critical for collagen synthesis. Without enough vitamin C, like in scurvy, collagen is weak and old wounds can literally fall apart. Vitamin A is important too. It helps with epithelialization and can actually counteract some of the negative effects of steroid medications on healing.
What else systemically?
Impaired blood flow and oxygen delivery. Hypoxia low oxygen is terrible for wounds. Fibroblasts need oxygen to make collagen. Phagocytes need oxygen for the respiratory burst to kill bacteria effectively.
Is that why sometimes they use hyperbaric oxygen for problem wounds?
Precisely. Forcing more oxygen into the tissues can help overcome that limitation in selected cases.
Immune system issues.
Definitely. Conditions or treatments that impair the immune or inflammatory response hinder healing. Diabetes mellitus is a major one.
How does diabetes affect it?
The hyperglycemia, high blood sugar, directly impairs neutrophil function. They don't move towards targets as well, chemotaxis, and they don't eat microbes as well, phagocytosis. Plus, diabetics often have vascular problems reducing blood flow anyway. And corticosteroid drugs, while great for reducing harmful inflammation, also suppress the beneficial aspects needed for healing. They decrease capillary permeability, inhibit fibroblasts, slow everything down.
Okay, what about local factors right at the wound site?
Infection is probably the biggest local enemy. It prolongs the inflammatory phase, disrupts collagen synthesis, prevents epithelialization. A clean wound is essential. Foreign bodies also delay healing. Dirt, glass, splinters, even suture material acts as a foreign body, potentially harboring bacteria and prolonging inflammation. That's why sutures are removed as soon as the wound has enough strength.
You mentioned bite wounds earlier.
Yes, bite wounds are a special case due to high infection risk from oral bacteria. Cat bites are particularly notorious, with a 30–50% chance of infection, often with Pasteurella multisida. Puncture wounds from bites are riskier than lacerations because they're harder to clean.
So treatment involves.
Thorough cleaning irrigation, maybe removing dead tissue debridement, and often prophylactic antibiotics, especially for bites on the hands or in immunocompromised people.
Does age play a role?
It does at both ends of the spectrum. Children and neonates generally heal faster and have a greater capacity for repair, but they have fewer reserves. Small fluid shifts can cause big problems, and their immune systems are still developing. In older adults, healing tends to be slower and less robust. The skin gets thinner, there's reduced collagen synthesis, fibroblast activity decreases. Plus, older adults are more likely to have those comorbidities we talked about: diabetes, vascular disease that further impair healing.
All right, let's try to tie this all together. A quick recap. Inflammation kicks off with vascular changes, causing the heat, redness, swelling, and then leukocyte action, mainly neutrophils, then macrophages, guided by chemical mediators like histamine and prostaglandins. That's the acute phase.
Right, and if that doesn't resolve, you get chronic inflammation with lymphocytes and macrophages, often leading to scarring or specific patterns like granulomas.
Then for repair, it's either regeneration if the cells are labile or stable, or scar tissue if they're permanent, fixed cells.
And that repair process follows the inflammatory proliferative building phase with fibroblasts and granulation tissue, and finally the long remodeling phase to strengthen the scar.
And we know nutrition, oxygen, immune status, infection, and age can all significantly impact how well that whole process works.
Exactly. It's a complex but logical cascade. Now, here's something to think about, connecting it all back. We know chronic inflammation drives diseases like arthritis and arterial stiffness. And we just discussed how the final remodeling stage of healing depends on enzymes, proteases, like collagenase carefully balancing matrix buildup and breakdown. Research is showing that unregulated protease activity is a key factor in those chronic diseases, breaking down tissues inappropriately. So the final thought is this: given that these enzymes are double-edged swords essential for normal remodeling but destructive when out of control, could finding ways to precisely modulate specific proteases become a major therapeutic strategy? Could we fine-tune them to both improve wound healing and control chronic disease progression at the same time?
That's a really potent question for future therapies, a fantastic point to end on. Okay, that wraps up our deep dive into inflammation and healing. We hope this detailed walkthrough has clarified these crucial processes for you. Conclude with a concise recap of the main takeaways and a warm thank you from the Last Minute Lecture team.